start, right?
No, do you know the number of participants who have registered themselves?
Yes, madam, I'll tell you.
How many? How many of us have registered ourselves?
60 participants, madam. 60.
60.
Yes, ma'am.
60, okay.
And Dr. Anvi madam has not joined it, ma'am. Madam, we'll start the program, ma'am.
Okay, then let us start. A very good evening to all the members who have joined. And now we are going to start with the program of respectful abortion care. I, Dr. Atima Bharti, will be, Dr. Suman Sinha was to talk on MTP Amendment Act 2021, but since she's busy today, so I'll be talking on this topic, and then followed by Dr. Meenakshi. She'll be talking on the techniques. So once again, a very good evening to all of you. So I'll be talking on the MTP Amendment Act, which took place recently in October 2021. on respectful abortion care. And this is an initiative, a joint initiative from FOXY and WHO. So what is the objective of this module? We need to disseminate this evidence. The latest law, which has been amended in 2021, this has to be disseminated through FOXY members. We will take a closer look at what are the new laws and what are the changes in rules. Since unsafe abortion in India leads to mortality, morbidity, and hampers the women and girls' full participation, and 8% of maternal death per year is due to abortion. This is the third leading cause of maternal mortality rate, and nearly 2 out of 3 of the abortion performed are deemed unsafe. Nearly half of the pregnancy-related deaths are in women and girls under 24 years of age. Now, when is abortion considered safe? It is considered safe when both the criteria are met. Number 1 is by appropriate method, and number 2 is by trained persons. And if only one of the criteria is met, then this becomes less safe. And if none of the criteria are met, then this is unsafe. So what is this amendment? Amendment has been done to make this abortion care safe and comprehensive, and this has been mandated by law. The previous act, all of us are aware of the previous act. In previous act, what was it? There was requirement of opinion of just one provider for MTP up to 12 weeks. You have to see the word provider, because this provider has been replaced in this recent act by registered medical practitioner. And there was requirement of option of 2 providers for 12 to 20 weeks. But now in this latest law, requirement is for opinion of 1 RMP for pregnancy termination up to 20 weeks of gestation, whereas 2 RMP's opinion will be required for termination of pregnancy from 20 to 24 weeks of gestation. So what is the potential outcome of this amendment? There will be increase in number of facilities, especially in public sector, like public health centers, eligible for service provision till 20 weeks. In previous act, MTP was permissible beyond 20 weeks only when it was immediately necessary to save the life of the pregnant women. But now, in this amendment, the upper gestational limit has been enhanced from 20 to 24 weeks for special vulnerable categories of women. And who are the special vulnerable categories? That I'll be explaining later on. There has been further enhancement for birth defects, which is not compatible with life, but for that we need medical board consensus. So what is the potential outcome of this amendment? There is increased access for vulnerable women to safe and legal abortion services, defined by rules committee, including the violence victims and minor, among the others. In the previous act, the act had the provision for termination of such pregnancies only up to 20 weeks. Upper gestational limit does not apply in cases of pregnancy with substantial fetal abnormalities, which is diagnosed by a medical board. There is no gestational limit if there is any congenital anomaly of the fetus. So this, what is the potential outcome of this amendment? There is increase in access to safe and legal abortion services, who often seek services late beyond the legal limit for termination of pregnancies with substantial fetal anomalies diagnosed late, and thus reducing unsafe abortion as well as the number of court cases. In previous act, the condition of failure of contraception was applicable only for married women or her husband. But this has been liberalized now. In the present amendment, the condition of failure of contraceptive is not really limited only to married women. It is for all women and her partner. So, what is the potential outcome of this amendment? There is increased access to safe and legal abortion for any women, irrespective of her marriage age, especially with upcoming changes in legal age of marriage. This is an important advancement for increasing access to safe abortion. Now, in the previous act, the Medical Termination of Pregnancy Regulation 2003, it mentioned that information should not be disclosed except under authority of law. But in 2021, it has been amended that name and all particular of a woman whose pregnancy has been terminated, it shall not be revealed, except to a person who is authorized by any law for the time being in force. Potential outcome of this amendment is there is increase in privacy and confidentiality of the abortion seekers, increased demand, but need to safeguard rights and dignity of women and provide respectful, bias-free services, including counseling and contraception. So this present act, it prioritizes confidentiality and at the same time, safety as well. Name and other particulars of any woman who comes for abortion has to be confidential, except to a person authorized in any law for the time being in force. And the ground for failure of contraception has been extended to all women and her partner. Under this amendment rule, there are certain definitions like special or vulnerable category of women, registered medical practitioner, and powers and functions of the medical board. So, special or vulnerable category of women. These women, they are eligible for an extended gestational period. The pregnancy can be terminated in these women until 24 weeks of gestation. And there are certain norms for registered medical practitioner whose opinion will be required for termination of pregnancy at different gestational age, like opinion of 1 RMP till 20 weeks and opinion of 2 RMP from 20 to 24 weeks. And beyond 24 weeks, in cases of congenital anomaly, it is the medical board that will decide. And medical board will be formed by a gynecologist, a pediatrician, plus a radiologist when available. And it is formed for each state, and it is mandated to provide timely evidence-based decisions. So under this amendment 2021, who are special categories of women who will be eligible for MTP between 20 and 24 weeks? There are special categories, 7 categories. Number 1, women who are survivors of sexual assault, rape, incest. Women with pregnancy in humanitarian settings, disaster, and or emergency situation as declared by the government. If there is any change of marital status during the ongoing pregnancy, either it could be widowhood or divorce. Women with physical disabilities. Mentally ill women, including those who are mentally retarded. Minors, less than 18 years of age. And fetal malformation that has substantial risk of being incompatible with life or if the child was born, it would suffer from such physical or mental abnormalities to be seriously handicapped. Now, what are the norms for RMP? Registered medical practitioner, defined in the old Act as MBBS or more, with any medical practitioner assisted in 25 cases of MTP of at least 5 done independently in a hospital, or those medical practitioners who has completed 6 months of house surgency in obstetrics and gynecology. Medical practitioner who has experience of at least 1 year in the practice of obstetrics. Now, 1 RMP opinion up to 20 weeks of gestation, 2 RMP opinion from 20 to 24 weeks of gestation, and beyond 24 weeks, medical board opinion is mandatory. Now, under the amended rules 2021, additional category of provider has been added. This is for termination up to 9 weeks with medical method. RMP with experience in the practice of obstetrics and gynecology at any hospital for 3 months, or training with performance of 10 cases of MTP by medical method of abortion under supervision of RMP in a hospital established or maintained or a training institute approved for this purpose by the government. So this 2 criteria, this is included for termination up to 9 weeks with medical method. So there are total 5 norms for the RMP whose opinion is required for termination of pregnancy at different gestational age. Till 9 weeks, we have this 5 norms. Number 1 is experience at any hospital for 3 months in the practice of obstetrics and gynecology, or has independently performed 10 cases of MTP by MMA under supervision of a RMP in a hospital established or maintained or a training institute approved for this purpose by the government. Second norm is a practitioner who has assisted a RMP in the performance of 25 cases of MTP, of which at least 5 have been done independently in a hospital. Third one is a practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology. Fourth one is a practitioner who has completed 6 months of house surgency in obstetrics and gynecology. And fifth one is a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of obstetrics and gynecology. And for till 9 weeks, opinion of 1 RMP is required. Now, till 12 weeks. Now, if the gestational age is limited, is extended up to 12 weeks, then we have 4 norms. 1 norm has been removed. A practitioner who has assisted RMP in the performance of 25 cases of MTP, of at least 5 have been done independently in a hospital. Second norm is a practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology. Third, a practitioner who has completed 6 months of house surgency in obstetrics and gynecology. And fourth one is a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of obstetrics and gynecology. And here again, opinion of 1 RMP is required. Now, beyond 12 weeks till 20 weeks. Again, opinion of 1 RMP is required here, but 1 norms has been removed, and there are 3 norms. A practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology, a practitioner who has completed 6 months of house surgency in obstetrics and gynecology, and a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of obstetrics and gynecology. Now, beyond 20 weeks till 24 weeks. The experience and training requirement for RMP is 3. A practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology, or a practitioner who has completed 6 months of house surgency in obstetrics and gynecology, or a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of obstetrics and gynecology. And here, from 20 weeks till 24 weeks, opinion of 2 RMP is required. Now, beyond 24 weeks, in cases of congenital anomaly, where opinion of medical board is required. The norms for the RMP are a practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology, or a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of obstetrics and gynecology. And opinion of medical board will be required here for the termination procedure. When advised by the medical board, it is carried out with all safety precautions, along with appropriate counseling and at an approved place. So who forms the medical board? The composition is a gynecologist plus a pediatrician plus a radiologist or sonologist. Now, what are the powers of medical boards? To allow or deny termination of pregnancy beyond 24 weeks of gestation period only after due consideration and ensuring that the procedure would be safe for the women at that gestation age, and whether the fetal malformation has substantial risk of it being incompatible with life, or if the child, when born, would suffer from such physical or mental abnormalities to be seriously handicapped. Other specialists can be opted for in the board, and other additional investigations can be asked for if required for deciding on the termination of pregnancy. And FOXI, with ministry guidance and WHO support as part of respectful abortion care, can operationalize and host medical board information on website. Now, what are the functions of medical boards? To examine the women and her reports who would approach for medical termination of pregnancy. Then provide the opinion of medical board in Form D with regard to the termination of pregnancy or rejection of request for termination within 3 days of receiving the request for medical termination of pregnancy. And to ensure that the termination procedure, when advised by the medical board, is carried out with all safety precautions along with appropriate counseling within 5 days of the receipt of the request for medical termination of pregnancy. And here FOXI has an important role to play in ensuring there are functional medical board in every state, as is stated in MTP Amendment 2021. So I request all members, don't miss the post-test and feedback form after this session is over, because you'll be eligible for the certificate only when you fill that post-test feedback form. Thank you all for patient hearing.
Thank you, Atmadi. Can I start now?
Yeah, Meenakshi, you proceed.
Yeah, yeah. Good evening, everyone. Now my screen is visible.
Yeah.
Uh, Today, my topic is safe abortion. What are the current updates in technology?
Madam, sorry to interrupt. It's not full screen, madam.
Okay.
Showing slides only.
Meenakshi, make it full screen.
Yeah. Now it is full screen. See?
Yeah. Yeah.
We are discussing about safe abortion. What are the current updates in technology? This session discuss 4 points. What are the existing guidelines? Pre-abortion assessment, medical methods of abortion, and surgical methods of abortion. WHO global guidelines on safe abortion is available. WHO has a lot of national publications also on safe abortion. This is Ministry of Health and Family Welfare National Guidelines on Safe Abortion, which show the rules which are changed on 24th September 2021. All guidelines have 3 key areas in management of abortion safely. First is the pre-abortion care, second abortion care methods, and third is aftercare and follow-up, including post-abortion, contraception, and counseling. First is medical history, followed by examination, lab and other investigation, and last there is discussion regarding contraceptive options. These are the points which helps the woman in making the decision. If the woman chooses to have an abortion, she should be allowed to choose from among the available methods that are appropriate for her based on the duration of her pregnancy and her medical condition. Coming to pre-abortion assessment and counseling. Components of pre-abortion assessment for women seeking first trimester abortions. First is detailed history taking, second general physical and pelvic examination, third is laboratory and other investigation, and fourth, the decision-making information on abortion procedures and counseling. Gestational age determination by LMT or physical examination. By 4 weeks, the uterus increases in size by approximately 1 centimeter per week. And after 12 weeks, uterus rises out of pelvis. After 16 weeks, uterus reaches the midpoint between symphysis pubis and umbilicus. At 20 weeks of gestation, uterus reaches the umbilicus, and after 20 weeks, the fundal height in centimeters measured from the symphysis pubis approximates the weeks of gestation. But there are cases when the uterus that is smaller than expected date. This may indicate that woman is not pregnant, or she has incorrect dating, ectopic pregnancy, or abnormal intrauterine pregnancy like spontaneous or missed abortion. And when the uterus is larger than expected, may indicate inaccurate menstrual dating, multiple gestation, uterine abnormalities such as fibroids, and molar pregnancy. Pre-abortion investigation. Routine lab tests are not a prerequisite for abortion services. Tests that may be performed as per individual risk factors on the findings of physical examination. Pregnancy test, if pregnancy is unconfirmed, hemoglobin or hematocrit for suspected anemia, RH testing, where RH immunoglobulin is available for RH negative women, HIV testing or counseling, STI screening usually performed during the pelvic examination, other lab tests as indicated by medical history, kidney or liver function test, etc. Ultrasound is not necessary unless to diagnose of pregnancy not certain or suspecting ectopic or missed abortion. Pre-abortion counseling. Ask thoughts about terminating the pregnancy and reason for terminating. Inform early abortion is safe. Importance of a trained provider performing the procedure for safety. Available methods of abortion, risks and warning signs associated with the abortion method. Without contraception, she can get pregnant as soon as 14 days after abortion. Resumption of her normal activity, including sexual intercourse, any other follow-up care. Document, informed written consent, decision to accept post-abortion contraceptive. Even if she is not willing for contraception, she will be provided with the abortion services. Clinical management of abortion. Abortion care in less than 12 weeks. It is recommended mifepristone and misoprostol only, and vacuum aspiration. When it is more than 12 weeks, mifepristone and misoprostol only, and DL. Not recommended in dilatation and sharp curettage. Medical abortion is recommended until 9 weeks only. First trimester, we have two choices, medical methods and surgical methods. In medical method, tablet mifepristone and misoprostol is recommended. Mifepristone, an antiprogestin which inhibits the action of progesterone. It interferes with continuation of pregnancy. Initial oral dose of mifepristone followed by misoprostol, a prostaglandin even analog. Misoprostol causes cervical softening, uterine contraction, and expulsion of product of conception. Protocols, the day 1 mifepristone 200 milligram is administered. If woman is Rh negative, she is given anti-D 50 microgram. Also, misoprostol up to 7 weeks, 400 microgram is recommended. That comprises of 2 tablets of 200 microgram each, either sublingual, buccal, vaginal, oral. And when 7 to 9 weeks, then 800 microgram is by sublingual, buccal, or vaginal route. In addition, we can administer analgesics, antiemetics, along with we can offer contraception if woman is accepting. Within day 15, follow-up day, confirm and ensure completion of the procedure, offer contraception if not already done. Characteristic of different route of misoprostol administration for first trimester abortion. Commonly, we use oral, in which pills are swallowed. This is recommended up to 7 weeks of first trimester abortion, and the side effects are diarrhea, nausea, fever, and chills. Buccal, the pills are placed within the gum and cheek and swallowed after 30 minutes. There is more fever and chills than vaginal route. Sublingual, pills are placed under the tongue and swallowed after 30 minutes. They increase fever, chills, diarrhea, and vomiting compared to vaginal route. It is the fastest route of onset of action and highest plasma level is achieved by this route. The vaginal route, pills are placed in the vaginal furnaces, the deepest portion of vagina, and the woman is instructed to lie down for 30 minutes. The pill fragments may be visible and it has lowest side effect. This is a picture showing the buccal and sublingual route. The blood drug regimens, dose schedule for medical abortions. Provision of medical abortion services. This should be available at primary care level with referral systems in place for all required higher level care. Additional services may need to be provided to individuals seeking medical abortion, counseling and testing for sexually transmitted infection, abuse support services, psychological or social services whenever needed, or other specialist health or medical services whenever needed. Provide iron tablets if woman is anemic, provide any necessary pain medications, and provide emotional supports if it is needed. Follow-up care. Routine follow-up not necessary following an uncomplicated medical abortion using mifepristone and misoprostol. A follow-up visit 7 to 14 days after the procedure may be offered to provide contraceptive counseling and services, emotional support, or address any medical concern. A routine follow-up visit is recommended only in case of medical abortion using misoprostol alone to assess success of the abortion. Follow-up care. is used to assess woman's recovery and ask for any signs or symptoms of ongoing pregnancy. Review any available medical records and referral documents. Ask about any symptoms experienced since the procedure. Perform a focused physical examination for any complaints. Assess woman's fertility goal and need for contraceptive services if not provided earlier. So coming to the summary of medical abortion, first visit, do a physical and pelvic examination, confirm eligibility, tablet mifepristone 200 milligram orally is given, offer NTD to RH negative. Tell the woman to return for misoprostol after 2 days, contact address and phone number of the facility center where she can go in case of any emergency, record her experience of any side effect on the MMA card. 3% of women may expel completely with mifepristone alone, but misoprostol schedule should be completed. On day 3, misoprostol 400 milligrams sublingual, buccal, vaginal or oral is given. Observed for 4 hours. Analgesics, ibuprofen 400 milligrams is given. Contraceptive options, condoms, hormonal methods, OC pills or injectable can be started at the same time. Tell the woman that mean period of bleeding is average 8 to 13 days. Possible side effects are nausea, vomiting, diarrhea, headache, fever, and dizziness. Report in case of excessive bleeding, pain, abdomen, and fever. Report if there's no bleeding after 24 hours of misoprostol. Consider giving additional doses of misoprostol. 75% of women abort within 4 to 6 hours after misoprostol administration. And third visit, that is on day 15, what to do? Pelvic examination is needed to ensure the completion of abortion, contraceptive option, then a hormonal method, OC pills, condoms, IUCD, sterilization. These can be offered at this time. And tell the woman about immediate return to fertility, that is within 14 days it may return. Report back if there is no period within 6 weeks of completion of the abortion process. And USG only if examination does not confirm the completion of the procedure. What are the side effects and complications? Pain, you should be respectful and non-judgmental. Verbal support is offered. Adequate counseling is must. Support person should be there. And Brufen 400 milligram is usual analgesic that is given. Even if there is persistent pain with failure to respond to these drugs for several hours warrants evaluation for other causes such as ectopic pregnancy, infection, or incomplete abortion. Nausea and vomiting are generally self-limiting and need only reassurance. Diarrhea is generally self-limiting and need reassurance. And infection is confirmed by physical examination and antibiotics should be started. What are the action for failure or incomplete results of MMA? Failure MMA offer vacuum aspiration or repeat MMA, depending upon the patient choice. Incomplete result of MMA, observe unless heavy bleeding. If bleeding is resolved and uterus size is normal, then abortion process is complete. If heavy bleeding continues, then offer surgical method, or either you can repeat the misoprostol. Excessive bleeding, generally bleeding which persists with her menstrual cycle and there's soaking of 2 pads an hour for 2 consecutive hours, then in routine care keep a watch on her vitals and bleeding TV, and if bleeding decreases over time then she can go home. If on pelvic examination POC is felt in cervical canal, then DNC should be done. USG indicated if there is minimum decidual beads there, and if woman is stable, product of conception and decidual beads is there, then misoprostol 600 milligram oral or 400 milligram sublingual is offered, or you can do a vacuum aspiration. And if there is continuation of pregnancy, then vacuum aspiration is advised. Recording and reporting for MMA. Since MMA comes under the purview of MTP Act, the documentation is similar to that required for the vacuum aspiration procedure. It is mandatory to fill the following forms. Form C, which is the consent form. Form 1, which is RMP opinion form. Form 2, that is monthly reporting form to be sent to the district authority. And Form 3 is the admission register for case records. Methods of first trimester abortion, surgical methods of abortion, that is MVA and EVA. Surgical abortion methods in first trimester. Vacuum aspiration is recommended technique of surgical abortion for pregnancy up to 12 weeks. WHO recommends manual vacuum aspiration as the safest method. The procedure should not be routinely completed by surrogate. Vacuum aspiration method. Procedure of abortion performed is same regardless of type of vacuum used. Manual vacuum aspiration, handheld aspiration, which is used to generate vacuum. Aspirator attached to cannulae of 4 to 12 mm in diameter. Cannulae can be used in multiple settings, including those without electricity. IPAS or EG grip cannula size corresponding with weeks of gestation, that is 8 mm cannula for 8 weeks of gestation and 10 mm for 10 weeks of gestation. Electric vacuum aspiration is an electric pump used to generate vacuum. It can accommodate cannula of manual vacuum aspiration with correct side tuning. Cervical priming may be considered for women with a pregnancy of any gestational age to prepare the cervix and make it soft and easy to dilate. Recommended method of cervical preparation before surgical abortion in first trimester is oral mifepristone 200 mg 24 to 48 hours in advance, or misoprostol 400 microgram administered sublingually 2 to 3 hours prior to procedure, or misoprostol 400 mg administered vaginally 3 hours prior to the procedure, or laminaria placed intracervically 6 to 24 hours prior to the procedure. Pain management plan for vacuum aspiration procedure. Important component of quality abortion care. It reduces pain and anxiety and makes women comfortable. Two components of pain management are there, that is non-pharmacological and pharmacological use of medications. Non-pharmacological provide psychological support, explaining each step to the woman in advance, performing the procedure gently and very smoothly, and encouraging to women to relax and take deep breaths. Pharmacological pain management. And anxiety, to tackle the anxiety, anxiolytics like diazepam or general anesthesia used. Diazepam 10 mg orally is given 1 hour prior to procedure, or 2 to 5 mg IV 20 minutes prior to procedure. Its duration of action is 4 to 6 hours, and side effect is disorientation and dizziness. Cervical dilatation, lignocaine or local anesthetic used, analgesics and NSAIDs like buprenorphine used. Lignocaine, 10 ml of 1% lignocaine, this acts for 60 to 90 minutes. It has side effect like dizziness, seizures, or gastritis can occur. With uterine cramping, analgesic ibuprofen used. It is used in dose of 400 to 800 mg 1 hour prior to the procedure. Its action lasts for 4 to 6 hours, and the side effect is gastritis. Steps of MBA. First, prepare the instrument. Second, prepare the woman. Ensure pain control medication is given at appropriate time. Ask the woman to empty her bladder. Third is perform the cervical antiseptic preparation. Fourth is administer paracervical block. And fifth is dilatation of cervix. And sixth is insertion of cannulae. Seventh step is the suction of uterine contents. Withdraw the cannula 1 to 2 centimeters away from fundus inside the uterine cavity. Rotate the cannula in 10 to 2 o'clock position with smooth, gentle motion, and release the vacuum button of the aspirator. Signs that uterus is empty: red or pink foam without the tissue passing through the cannula, gritty sensation over the surface of uterus, cervix gripping over the cannula, uterus contracting around the cannula. There is increased uterine cramping. Step 8 is inspection of the tissue that has been removed by section. So step 9 is concurrent procedure. Proceed with contraception such as sterilization or IUCDs. Insertion. And step 10 is instrument processing. Instrument should be soaked in chlorine solution 0.5%. It assists disinfection and helps remove tissue and body fluids. Post-procedure care. Monitor her for any complication and provide management as needed. She may leave the facility when she is stable and meets the criteria for discharge. Ensure that the woman has all necessary information and medication prior to leaving the facility. Document all outcome of the treatment, including any adverse events, in the facility register and client's record copy. Aftercare. Management of abortion complications, that is incomplete abortion, infection, bleeding, ongoing pregnancy. Provision of contraceptive information and offer contraceptive counseling and methods. Assessment of any other sexual and reproductive health needs that may require additional care. Follow-up. No routine follow-up unless measure alone regimen is used, which is the new recommendation. In summary, India has made historic progress in improving access to safe abortion. Not much has changed in technological update in the last decade. As providers, it is up to us to ensure safety and quality, especially in context of the amended law. Along with safety, we also need to focus on respectful abortion services. Every client, public or private, an opportunity to inform, educate, and equip with proper information on contraception and counseling. So every participant is requested to please fill the post-test and feedback form which is provided at this end of the session. Thank you. Hello, Atmadi.
Yeah, now I'll be sharing my screen.
Okay, Dee.
So can you see my screen?
It's not full screen, madam.
Okay. It's okay now?
Yes, ma'am.
Yeah. So now module 3, this mainly deals on the behavioral aspect of the healthcare providers or respectful abortion care. So what does this SAVER mean? SAVER is safe abortion values, evidence, rights, and respect for respectful abortion care. So this module aims to define respectful abortion care by the WHO standard. It will highlight how norms and stigma affects in hampering the respectful abortion care services. So as health provider, we need to be very careful with our language. Don't use language that stigmatizes the women. And provide WHO SAVER resources for respectful abortion care that I'll be showing a small video on it. Now, what is respectful abortion care? This has been adopted from respectful maternity care recommended by the WHO, and it refers to care that maintains safety, dignity, confidentiality, ensures freedom from harm and mistreatment, enables informed choice, and continuous support during as well as after all types of abortion. So in simpler terms, respectful care means you as a provider and or as a patient treat and are treated with dignity, empathy, and compassion, regardless of your race, ethnicity, gender, socioeconomic status, or reproductive history. We as health providers, we don't have to question the women. Suppose if she's coming to us for a third time, we don't have to question the woman that every now and then you are coming for abortion, because abortion is her right. And we as healthcare providers have to provide her with safe abortion care. If you ever feel that something isn't right, then speak up. As health professionals, it is our duty to listen and support the women. Communication is a key factor to develop a very good rapport with the patient. Now, what are norms and stigma? This is a short video on norms and stigma.
Social norms are the unwritten rules of behavior that are considered
hope it is
acceptable
audible.
in a group or society. Norms can change according to the environment, situation, and
Is it
or
audible?
culture in which they are
Yes,
found.
ma'am.
People's
Yes, ma'am, it's
behavior
audible.
will also change
Yeah.
accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects, and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex-selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others, personally and professionally.
So stigma and norms, they perpetuate disrespect and abuse, and that has to be avoided while providing care to the women. There are 7 categories of disrespect and abuse. Physical abuse in the form of slapping or intimidating physically. Verbal abuse like non-consented care, shouting and screaming at the women. Sexual abuse in the form of abuse of power or taking advantage. Stigma and discrimination, which is provided in the saver videos. Failure to meet professional standards of care. Poor rapport between women and the providers. And lastly, health system condition is if the health system condition is not appropriate, then that is also a category of disrespect and abuse. Every woman has a right to freedom from harm and ill treatment. She has a right to information, protection under the law, MTP and POXO, informed consent and refusal is her right, respect for choices and preferences, dignity and quality of care is the right of every woman. The right to timely health care and to the highest attainable level of health. Liberty, autonomy, self-determination, and freedom from coercion is the right of each and every woman. There are 12 domains of respectful abortion care, and this has been adopted from respectful maternity care. Number 1, being free from harm and mistreatment, maintaining her privacy and confidentiality at the same time, preserving women's dignity, her choices, respecting women's choices, engaging with effective communication. These are soft skills which has to be done to develop a good rapport between the women and the healthcare provider, providing information and seeking her informed consent, ensuring continuous access to support during and after abortion, enhancing the quality of physical environment and resources, providing her with equitable abortion care, availability of competent and motivated providers. There should be provision of contraception advice and commodity security. And lastly, the care and counseling should be in a continuous manner. So again, there is a short video on WHO training for safe abortion values.
Madam, you missed the other video, madam. Can you go back?
Sorry?
You missed another video also, madam. Can you just go back once?
No, there's no video. After this is the video.
Okay, ma'am.
One video I have already shown. I have shown one video on nonsense stigma.
There is
And
another
this-
video, madam. Okay, ma'am. I'll play the video. You just go ahead, ma'am.
This is a video on Saver Toolkit.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO SAVA, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO SAVA toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. SAVA has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. SAVA is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
Now there is another video on Guide to Avoid Stigmatizing Language.
Madam, make it full screen, madam.
Yeah.
How to talk about abortion, a guide to right-based messaging. How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or Registered Medical Practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix "side" denotes killing, which is not appropriate when describing abortion. When referring to sex selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights-based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business-related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider or when a person has access to high quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the 3 P's provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex-selective abortion is illegal. Provider and place need to be safe, trained, and certified.
So in this video, you saw how we should avoid stigmatizing words which hurts the sentiment of the women. We have to be very careful in choosing our words while communicating with the women. So now you have seen that the law has changed, and as health providers, we have to provide support and we have to disseminate this law. And Foxy is the largest provider base for abortion care. Online training was possible due to COVID, so that respectful abortion care can reach all the providers in this country. Medical method of uptake of abortion uptake has also increased because it is early, safe, it ensures no PC-PNDT conflation. It is the patient's safety, respect, and quality matters more than ever. And we as health providers have a role to play. Time has come to strengthen the implementation of this law. Every patient is an opportunity for respect. And as providers, we have the onus on us to educate and also to reduce sex-selective abortion. Up to 20 weeks of gestation, it is the responsibility of one RMP to counsel regarding contraception, referral, at the same time provide her with compassionate care. From 20 to 24 weeks of gestation, there are special categories of women, like young people less than 18 years of age, survivors of rape, incest, unmarried women, and all of them, they need unbiased care. And we as health provider, we need first to overcome our own biases. 20 to 24 weeks of women, since these women are of special categories, so they need to be treated with much sensitivity, judgment-free, and timely services should be given. This law, it also prioritizes confidentiality and safety
Madam, I can't hear you.
Yeah. एक मिनट
Meenakshi ma'am, can you please interact with the participants, madam?
Good evening, everyone. Atima ma'am's internet is not working. So shall I go ahead with module 4 now? Okay, I'll start sharing my screen.
And ma'am, just complete the third topic, madam. Then you proceed with your fourth topic, ma'am.
Okay, just give me a moment, then I'll down. Yeah,
Okay.
just give me a moment.
If you ask me to share, I'll share the screen, madam.
Yeah, please share the slide. I don't have that one.
Okay, ma'am, I'll do that. My screen is visible, ma'am.
Yes, it is visible. Can you just, yeah, till where ma'am?
From here, man, the videos
I
has
think
done.
ma'am had like almost completed her slides. So
Yes, ma'am. Video. There will be a question and answers, madam. Next.
yeah,
After this.
Yes, yes.
Should I change the slide, madam?
Yeah, yes.
You just proceed, madam.
Yeah, so from 1970, from unsafe abortion to 2000 safe abortion, and now we have come to 2020 where we are focusing on respectful abortion. So there are some recap questions that we'll be going through. So according to the World Health Organization, restricting access reduces the number of unsafe abortion. True or false? So can you write in the chat box, everyone? Yes, this statement is false. So when is abortion considered safe? So if it is done by appropriate method, it is safe, like both criteria is met. And if it is done by trained person, it is safe. Can we go to next slide? So a 30-year-old woman recently widowed wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. Yes or no? Please write in the chat box. Okay, we have a couple of answers. It is not our responsibility to tell her to continue this pregnancy. It is on the women to continue the pregnancy or not. And here is just a gist or revision of what we have discussed earlier. So up to 20 weeks of gestation, only one RMP is needed. One RMP's opinion is needed. From 20 to 24 weeks of gestation, 2 RMP's opinion is needed. And beyond 24 weeks, if the baby has birth defect, then medical board's opinion is needed. Can we have the next question? Okay, so in India, abortion is legal, and let us make it safe and respectful. Okay, that was the third module. Now I'll start with my discussion, which is on post-abortion family planning services. Are my slides visible?
No, madam. Madam, can you make it full screen, madam?
Yeah. I think, can you share the slide, my module? I'm not able to share. There is some issue.
Okay, ma'am. Okay, ma'am. Do that. Is my screen visible, ma'am?
Yes, yes, it is visible. So in the last module for the day, we'll discuss about pre and post abortion family planning counseling. Next slide, please. So what is counseling? Counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. Next slide. So pre and post abortion counseling is integral part of comprehensive abortion services. It is as important as the procedure, and women may need help in decision making. So wherever needed, the spouse should also be counseled. Next slide. Pre-procedure counseling, it plays a critical role. It helps women decide about termination of pregnancy. It helps women to choose the method of termination. It ensures delivery of complete information about the procedure and helps a woman to adopt a contraceptive method. Next slide. So the procedure for pre-procedure counseling, how should we go about it? First of all, we should ensure privacy and confidentiality and be non-judgmental and sensitive. We should establish rapport, use simple language and allow the woman to clarify her doubts. And if she has made up her mind for termination of her pregnancy, we should assess her for the procedure. Next slide. So the relevance of peri-abortion family planning counseling is because like after abortion or like after the MTP, there is quick return of fertility, and there is opportune time for contraceptive acceptance. There should be a minimum gap of 6 months before next pregnancy, and we should explain her about health benefits and better future pregnancy outcomes, because 90% of abortion related maternal mortality can be prevented by ensuring contraception. Next slide, please. So pre-abortion family planning counseling, when to start? It should be started on first visit or consultation, and we can make an exception when for grief management, we can delay it when there is missed abortion, spontaneous abortion, the lady is not able to accept the fact. And what should we counsel about? We should tell her that the importance of family planning, because the return of fertility can be as early as 10 days till 4 weeks. We should help her with the choices, and we should be method specific. There can be like high risk behavior. We should explain her when it is indicated and what is contraindicated. If the woman is not willing for any contraceptive method, we should not refuse MTP. We should try and counsel her after the procedure. If she is still not willing, we should call her for follow up in a week's time and again counsel her. Next slide, please. So assessing suitability for post-abortion contraception, what are the general guiding rules? So the abortion process should be complete. There should be no existing infection. There should be no injury to genital organs, and chances of fresh pregnancy should be ruled out. Then only we should go ahead with post-abortion contraception. Next slide. Post-procedure counseling also plays a critical role. It ensures women has understood precautions and care needed during post-abortion period. It gives an opportunity to counsel for contraception in case not previously accepted, and it reinforces the need for continuing the use of contraceptive method chosen. Next slide. So the procedure for post-procedure counseling, it is continue to ensure privacy and confidentiality, reassure her in case of any problems, and repeat the information about post-procedure care and danger signs. Next slide, please. So post-abortion family planning counseling, if the patient has already opted for a method, then we should appreciate her. We should tell her immediate care we can provide by intrauterine copper device or injection MPA, or we can give her oral contraceptive pills. We should explain her about the follow-up protocol, continuity, and we should give her the cards. And if the patient she has not decided about the method of contraception, we should allay her anxiety. We should explain the importance of immediate adoption and the method which she has chosen. Extended period of adoption should also be explained. Couple counseling should be done, and she should be explained about emergency contraceptive pills. Next slide, please. So now we'll discuss about the different post-abortion contraceptive methods. The first is barrier method, in which condoms come. So after first trimester, it can be used as soon as sexual activity is resumed. And after second trimester, it can be used as soon as sexual activity is resumed. So the benefits is that it has no hormonal side effects. It can be used without consulting a health provider. It is easily available. It prevents against STIs, including HIV, and it enables men to take responsibility of contraception. Next slide. Second, we'll discuss about intrauterine contraceptive device, which includes IUCD 380A and IUCD 375. So after first trimester abortion, it can be inserted immediately or up to 12 days after confirmation of completed abortion using the surgical method. And with MMA, it can be inserted around day 15 of the process, provided complete expulsion of product of contraception is confirmed and risk or presence of infection or any other contraindication is ruled out. And after second trimester, it can be inserted immediately or up to 12 days after the procedure is completed. And it is highly effective. It provides long-term contraception for 5 years for IUCD 375 or 10 years for IUCD 380A. It can be provided by trained doctors, ANMs, nurses after first trimester surgical abortion, by trained doctors only after MMA, and by PPIUCD trained doctors after second trimester abortion. No interference with sex, immediate return to fertility on removal, and it has got no hormonal side effects. Next slide, please. Third, we'll discuss about hormonal contraception, which includes combined oral contraceptive pills. So after first trimester, it can be given immediately or up to 7 days after abortion using surgical method. And with MMA, it can be started on day 3 with the dose of misoprostol or within day 15 of the process after confirmation of completed abortion. After second trimester, it can be given immediately or up to 7 days. The additional benefits are that it regulates menstrual cycles, can be provided by all health workers after first screening by trained provider. It has got no interference with sex, offer protection against ectopic pregnancy, endometrial and ovarian carcinoma, and benign diseases such as fibrocystic and fibroadenomatosis. But it is not suitable for women who are breastfeeding babies less than 6 months old. Next slide, please. The other hormonal contraception is long-term injectable, which is medroxyprogesterone acetate injection. After first trimester, it can be given immediately or up to 7 days if the abortion has been done by surgical method. And with MMA, it can be started on day 3 with the dose of misoprostol. After second trimester abortion, it can be given immediately or up to 7 days. The benefits are that it is highly effective, confidentiality and privacy is maintained. It can be provided by doctors, ANMs, nurses, after screening by the doctors for the first injection. It has got no interference with sex, no effect on the quality and quantity of breast milk, no estrogenic side effects. It offers protection against ectopic pregnancy, ovarian cancer, iron deficiency anemia, and uterine fibroids. Next slide, please. Fourth is permanent method, in which female sterilization comes. After first trimester, it can be performed after an abortion in the absence of any infection or severe blood loss, concurrently or up to 7 days. It can be both mini-lap and laparoscopic. And with MMA, it can be done only after the first menstrual cycle. For second trimester, mini-lap sterilization can be performed concurrently or up to 7 days after an abortion in the absence of any infection or severe blood loss. Laparoscopic sterilization is not recommended after second trimester abortion. So female sterilization is permanent method of contraception. It is highly effective. It is effective immediately. It has got no interference with sex, no effect on breastfeeding. It has got no long-term side effects, and it offers protection against ovarian cancer. Vasectomy is performed on males, and it is independent of the timing and procedure of the abortion. It is also very effective and permanent method of contraception. It has got no interference with sex, no long-term health risk, but couple must use another method of contraception for the first 3 months. Next slide, please. So here is the gist of contraceptive methods which can be provided with MMA. And here we see that combined oral contraceptive pills can be provided on day 3 with misoprostol, and it can also be provided up to day 15. Injection medroxyprogesterone acetate, it has to be provided on day 3 with misoprostol. Centromin also has to be provided on day 3. IUCD can be inserted up to 15 days of abortion. And tubal ligation, as we have discussed before, it can be performed concurrent. For MMA, it has to be performed only after the first menstrual cycle. Next slide, please. So here it is shown contraceptive methods with vacuum aspiration. And here we see combined oral contraceptive pills. It can be given. Injection centromin has to be given, but injection medroxyprogesterone acetate has to be given up to 7 days. Centromin also has to be given up to 7 days. IUCD can be given, but up to 12 days. And tubal ligation, it can be done concurrently or within 7 days. Next slide, please. So sexual and reproductive health services, now teleconsultation and other technologies have come up, which we'll discuss. Next slide. So service provision these days can be in the form of teleconsultation, telecounseling, teleguidance, telereference, and telelinkage. Next slide. So Techno IEC, which is information, education, and communication, can be provided by different medium. Like website, we have Hamdo. Social media, we have Ask Tanu and YouTube. Infographics, helpline, and there are various patient education platforms, including WHO, Ministry of Health and Family Welfare, and RCOG. Next slide, please. So we'll discuss the SWOT of teleconsultation, which includes strength, weakness, opportunity, and threat. So what is the strength of teleconsultation? In COVID area, it has become very important. It is approachable throughout the process. It is confidential, and awareness can be spread. The weakness is that it lacks face-to-face interaction and various methods of demonstration. Opportunity it provides is that it provides privacy and comfort. It is cost saving. It cuts down on the cost of traveling, and the number of visits is also cut down. Threat is that sometimes we miss the opportunity and sometimes misdiagnosis can be made. Next slide, please. Applicability of the components of comprehensive abortion care. So first, we have to assess. Assessment is important for confirming the diagnosis and to see if for the adequate contraceptive need. Counseling can be done through video conference and Zoom, and follow-up can be done. It can be made hybrid, like the patient can visit for one visit, and then the patient can be followed up on teleconsultation for MMA. But if 3 visits are required, so the number of visits can be cut down. Next slide, please. So the key messages of this module is, we should realize the need of post-abortion family planning. We should bring the couple on board and strive for 100% coverage. We should capitalize on the basket and applicability in the post-abortion period. Technology should be included, and it has a scope for entry in comprehensive abortion care services. The concern should be addressed, that is the policy, malpractice, service cost, and access. And adolescent reproductive health needs both online and offline care. Next slide, please. So registration and pre-test and post-test is needed, as well as feedback. Certificate will be awarded to participants on attending the training and submission of registration, pre-test, post-test, and feedback. Thank you.
So please don't forget to do the post test. When you log out, you will get an option of continue. You click on continue, and then you'll get the post test questions. You answer the questions, and then you'll be eligible for the certificate. So last time, many of the members, they didn't do the post test. So Mr. Simran, if you have the link, you can give the link so that those who have missed, they can do it on the link. Mr. Sriman?
I've posted the link in the chat box, madam.
Yeah, so those who had missed last time, can they do it on this link?
If you click on the link, you will be redirected to the post and feedback, madam. Just answer all the questions and submit, and we'll issue the certificates within a weekdays.
Okay. So thank you all.
Mm.